shareholders of a better world. Brought to you by TBLI Group. At TBLI Group, we have an established reputation as an organization dedicated to building the ecosystem of global sustainability and impact investing. We're doing this through educating, advising, and facilitating transactions in global sustainability and impact business, as well as capital solutions for private companies, family offices, and fund groups. For nearly 25 years, TBLI Group has created a vertically integrated ecosystem of education to action through TBLI conferences and TBLI consulting. More about our company can be found at tbligroup.com. This webinar is brought to you by TBLI Foundation, which hosts educational learning experiences dedicated to a better planet. Through the foundation, we build sustainable communities by sharing the people and the experiences making a difference to so many of our lives around the world. Our weekly podcasts bring impact thought leaders that are doing and not only chatting. Now let me introduce my guest today. Good afternoon from our studio in Amsterdam. Before I introduce our very special guest today, Allison Sesso, I just want to give you some instructions. If you've never used the system before, if you want to clap or find something funny or brilliant, there are 3 emojis that you can press and that'll capture that. If you want to send a private message to anyone in the room, just move your cursor or your mouse over their name and a window will pop up. And then you can send them a private message. And if you want to pose a question or a comment, just type it in the lower right-hand corner, and I'll take that afterwards. So I'm really thrilled today because Allison Sesso, who's the head of Rest in Peace Medical Debt, when I read about her, I found it absolutely brilliant, eliminating something that we don't understand that exists in Europe. What is medical debt? And also I found out later that in her previous job, she was instrumental in supporting my mother for quite a few years through supporting self-help. So Allison, please, for those of the audience that are not familiar with Rest in Peace Medical Debt and the work that you do, please explain and inspire us. So if you turn on your video and I'll go on mute. Thank you again.
Yeah, no, thank you so much for having me. I appreciate the opportunity and always happy to talk about my work, although my caveat is always that I wish I didn't have to, because the problem of medical debt in the United States is one that is unique and unfortunate and is really the result of a broken system. But we are actively buying as much medical debt from individuals as possible in order to relieve them of that debt. And so, RIP is a charitable institution. We take donated dollars, we bring them to the market, and we have been able to buy for pennies on the dollar because there is a market for medical debt in the United States, and we mimic that. We've been able to buy over $7 billion of medical debt in US dollars for helping 4 million people, which is exciting. But at the same time, we really want to leverage our work to talk about the problem more in a more macro sense and really talk about the systemic nature of that problem. We are gearing up to do more and more debt relief. I can certainly walk through some. I have a couple slides I could share to sort of wrap people's heads around the problem. So I think that might help articulate some of the problem in the United States. Especially
a lot of Europeans don't understand the concept of medical debt. How does that happen?
Yeah, exactly. So let me start there before I even bring up the slides, which the problem is, the problem in the United States is to the tune of $195 billion. It's a huge problem. In the U.S., we don't have the federal government, the state governments don't pay for medical care. They only pay for people that are at the poorest levels through a Medicaid program. And then elderly people, they subsidize through a Medicare system. But even that, you could end up with medical debt if you're on Medicare. And so unless you're really, really poor, you don't get care. And in that case, that system does work for people and they don't end up with medical debt. But anybody that's even slightly above poverty can end up with medical debt because we fund our healthcare system through employers And there's unfortunately, for-profit motivators within the system, so that the insurance companies are for-profit, so they're looking to make money. And then the hospitals, while they're technically nonprofits, they're incentivized to make sure that they're covering costs and are in an untenable position, I think, increasingly as costs of health insurance go up and we become more sophisticated about the kinds of care that we're providing to people. And so it ends up really in a situation where increasingly the cost of healthcare ends up falling in the laps of the individuals. And they end up with insurance that doesn't really cover the cost. So you have like $1,000 deductible or a $2,000 deductible or a $3,000 deductible when you don't have that much in savings. So if you end up using your health insurance, you end up having to pay this high cost that you can't afford. And so frankly, you should have never been able to have that kind of insurance. But in order to the cost of insurance itself is so high that people are in an untenable position where they can only afford insurance that leaves them with a high deductible. And then when they go to use that health care, they end up with that cost on their backs. And what happens, unfortunately, is that hospitals, debt collectors, et cetera, can really go after you. And the laws are set up so that you can have your a lien put on your home or on your car. You can have your wages garnished. So you can't really ignore the problem in a lot of cases. And then it also impacts your credit. So your ability to borrow, to buy a house, to buy a car, and all of that gets diminished. And then people just feel a real sense of mental anguish, obviously, because of this debt. Not only because of the fact that it hurts you financially, but people feel a responsibility to their costs. People don't like being in debt, and it really undermines their overall well-being. And so what we're seeing, unfortunately, in the United States is that more and more people have medical debt, and it is actually impacting the medical debt itself is a social determinant of health. So the medical debt itself is creating an ill health situation for more and more individuals because it impacts their mental health because of the anxiety about having a debt, the fact that people are going after them, calling them constantly to make payments. And then they also avoid care. So even if you don't have medical debt, you know that this is the situation in the United States. And so you wait and wait and wait when you feel sick. We literally have people sitting in the parking lots of hospitals with a pain, let's say, in their belly, and they're waiting to see if the pain will subside before they go in because they want to avoid going in. I mean, it's that bad. And there's people that avoid. So going into an ambulance, it costs you a bunch of money. So we have a situation where people literally will refuse to go in an ambulance, or if they need to get to the hospital, they will call an Uber or some other car service. You should talk to Uber drivers. It's insane, bleeding people in their cars to get to the hospital because they know that's cheaper. They know that that's a certain amount of money as opposed to the ambulance, which would be astronomical. And so we're putting financial pain onto people who are simply trying to get, basic medical care. Oftentimes I hear, people talk about this issue and say, healthcare is a right. And honestly, in the United States, it's not. So I haven't lifted up my slides yet, but I figured should I go ahead and keep going?
Yeah, are your slides going to show how you actually leverage philanthropic? Because I think I was amazed at the leverage, the percentage that you're able to eliminate with very little money.
Yeah, so obviously this is a big problem, and people are frustrated by the lack of action by our politicians and all of that. And so I think what our organization, RIP Medical Debt, provides is a solution that people can take action today, now, and help people get rid of medical debt. And I will share my slides so I can show you a little bit more, Paul, because it's not something that you would normally understand or that's easily understood. So let me do that really quick. Okay, hold on. Okay, can you?
Yeah.
You can see my slides, or you see my screen?
Well, we see a screen. I think you might want to choose that. Okay. There you go.
Yep. Okay. Let me just do the slideshow view.
Yeah.
Okay. Okay. So you see it as a slideshow? Hold on. Just make sure.
No, you have to do full screen in the lower right-hand corner. You see that little screen there? Next,
Yes. Okay. Thank you. You're a godsend. Okay. All right. So this is our organization. Obviously, what we think about in terms of this problem is that medical debt abolishment is an economic and social intervention, right? That we're actually helping people both economically and as a result of that, like improving their social situation. So our mission really is to end medical debt, and when we say that, we mean that on a couple of levels. One, certainly, helping individuals with our unique approach, which again takes advantage of the for-profit debt buying market that exists out there. We take donated dollars and we relieve debt. So I'll get more into that, but that's the first level of how we think about ending medical debt, literally for the individuals. And again, we've helped over 4 million people. But we also think of ourselves as helping the hospitals deal with a problem, because the medical debt problem also is a problem for hospitals. They end up with all this debt on their books that they really can't collect on because it's for people who don't have the money to pay. And so we offer a solution for them to remove that debt from the individual in a way that is, demonstrates their commitment to the community and their appreciation for the impact of medical debt on those that they serve. And then lastly, we really see ourselves as the mere existence of the work that we do demonstrates that there's a bigger problem in the United States, and we're really trying to leverage that for larger change. So as I mentioned earlier, it's a $195 billion problem in the United States, and it actually could be bigger than that. It's a hard number to actually capture because it sits sometimes on credit cards, it sits at the hospital, on hospital ledgers, it sits in a lot of different places, and it's really hard to get an exact number, but there's at least $195 billion, which is huge. So this is RIP. So we take donated dollars, and actually increasingly we've gotten just recently in the last year government interested in funding us as well, which is interesting and ironic in some ways. But we take the government dollars and we bring them to the market. So we combined donated dollars. It could be large donations. It could be combined with smaller donations, and we go to hospitals. And we go to other healthcare providers like big physician groups and things like that. And we get their bad debt portfolios, and we literally analyze them. We've created a proprietary, what we call a debt engine, that does this analysis in the background. So you take a very large file, you buy data from like TransUnion or Equifax, these agencies that help analyze people and collect information on people's income and other elements of who they are. And we buy income information and the economic status of the individual. We pair that in the debt engine with the file itself. And we identify everyone that qualifies, which is for us, anyone who is at a certain level of poverty and below. It's actually above poverty. It's 4 times the U.S. poverty rate. So roughly, basically under $100,000 for like a family of 3 or 4 annually. And then also, if the debt, you could make more than $100,000 a year, but if the debt is large compared to your income, so if it's 5% or more of your income, you will also qualify. So those are the individuals who we qualify. Usually that's a large percentage of the file. I mean, that's why the hospital hasn't been able to get money from those individuals, because they don't have the money to pay. And so it could be like 80% of the file. We will price that debt based on our proprietary pricing model, which mimics for-profit debt buyers. So in the United States, there are for-profit debt buyers that also buy debt from the hospitals in the same way I sort of just described, except maybe they're not analyzing it for, they'll buy the whole entire file and just really harass people, take them to court, do whatever they need to collect on their investment when they buy that full file. And so we're really competing with the for-profit debt buyers. So once we buy that file, once we analyze the file and we identify and price it, we will literally send money to the hospitals, but it's pennies on the dollar, and I'll explain that in a second more. And so then the hospital, gives us the debt, and we just send letters to all of the individuals. So you can't apply for the debt relief through RIP. It just happens when we buy your debt, and we will let you know that we bought your debt and you are free and clear of it for the rest of your life. And so that's, I think, the beautiful element of our model is that you can't apply for it. We don't expect anything of anybody to take an action on their own, but yet they get relieved of the debt. So just to give you a sense of this, the $1 of a donation to RIP relieves on average $100 of medical debt. So you can see the multiplying effect of this, $100,000. You can see the numbers right here. Like it's just amazing how much debt we can get rid of because of this market for medical debt. And just to pause on that point a little bit more, because I understand that you're probably not familiar with why there's a market for medical debt. Everything's a commodity in the United States, I think. When a for-profit debt buyer buys a portfolio from a hospital or a physician group, and again, they'll buy the whole thing, they're buying it on the bet that they'll be able to collect some portion of it from individuals, either again from just harassing them enough or taking them to court and garnishing their wages, or if they suddenly, maybe they were poor at the moment that they got care, but then they get a better job or they get an inheritance, that's when they'll go after them. So in order for them to make money on that portfolio and to ensure that their investment's going to pay off and be profitable, they have to buy it at a very, very deep discounted price. And that is basically what RIP is mimicking, except we are doing the opposite. We're more interested in the people who can't pay and are poor in that portfolio, and we would never collect on it. And we're using donated dollars to buy that, so we don't need to make a return on our investment in the same way. So this is just I won't go through this slide, but I will say we received a $50 million gift from MacKenzie Scott in December of 2020, which we are putting to good use. MacKenzie Scott is the ex-wife of the founder of Amazon, Jeff Bezos. She is giving his money away or her money away that she got from the divorce settlement. And we were the recipients of that unrestricted gift. And we're using it not only to buy debt directly from recipients, for recipients, but also to invest in our own processes and to make sure that debt engine that I mentioned is really as effective and efficient as possible, that we're investing in ways to tell the stories of individuals that are impacted by medical debt and really just getting out there as an organization. So that's who we are. And, we're funded, traditionally by faith-based organizations. So a lot of churches support us, foundations, corporations do it for a corporate social responsibility, because we do actually name, if they want, we'll name the entity or individual that funded the debt relief for individuals in the letter that we send. So I think that's very attractive to people. We find it's a win-win, as I mentioned earlier. This is just a little bit more about the process and how it works, which I feel like I covered earlier, so I won't go too much into that. And just to show you, press is very interested in this, and hospitals get a lot of good public credit when they work with us, because it shows that they're doing the right thing to do, right? That they're actually doing right by the individuals out there. And they get credit. So I think that's an extra incentive for hospitals to work with us. And so, I talked about this a little bit, but I just feel like I'll pause and go back to this point of why medical debt is a problem. It is really different than other kinds of debts. It is not one you can control for. You can do everything right and you still end up with medical debt. This last bullet down here, in the United States, getting sick, not whether or not you have insurance or an uninsured, et cetera, is the biggest predictor of medical debt. And so that's a really scary statistic. It shows you that there's really a lack of control by the individual over this. And so it's really funneling money from poor people into a for-profit system, and it's costing government, I will say, more and more money as well, because they are plugging the holes of this broken system. And increasingly, in the U.S., people don't have. It's an economic problem. People don't have, as I mentioned earlier, $400 to pay for the deductibles that are required. And so a lot of the debts we relieve are not $90,000, but they're $4,000, $2,000, they're $500, they're smaller amounts. And like so many other things in the United States, it is more prevalent in communities of color because of our history of slavery. And so that does, just has a disproportionate impact on them. And therefore our work, we have to do more research on this, but we believe it disproportionately supports people of color. It's the leading cause of bankruptcy in the United States. And as I mentioned, it is itself a social determinant of health. It impacts people, mental health, as I mentioned, financial health, and overall physical health, because they avoid going to get the care that they need. This is just demonstrating what I mentioned earlier, that you could see, $1,000 to $2,000, $2,000 to $5,000. Those are the amounts of debts that people tend to have. Only 13% are more than $10,000. And, not for nothing, but 250 to 500 people, 13% of them have, not people, $250 to $500, 13% of people can't even pay that amount and are in debt for that much money. So it's an interesting problem. What people are doing to pay their medical debts, and you had multiple choices here, which is why this doesn't add up to 100. They're cutting their own budgets and spending on things like clothing and food. They're taking additional jobs. They're using a lot of their savings, which frankly just kicks the problem, down the road for them. They're putting more money on their credit cards, which again kicks the problem down the road, and borrowing from friends and family. This just demonstrates the differential impact I talked about on people of color. You could see Black households are 28% compared to all, which is 19%, and white households are 17% in terms of the impact. So, I think that what I want to say here is that by doing this debt relief work, it provides emotional relief to people. It repairs their credit scores, and it just, it helps them have a little bit more wiggle room in their personal budgets, which I think is really, really important. And we can see that in some of the letters, which I will share with you. This is just telling you that when we think about policy change, we think about it on different levels. Institutional means like at the hospital level. So when we work with a hospital, we don't just we give them information that hopefully improves their ability to provide free care to more individuals. So hospitals in the United States are supposed to provide some level of free care to individuals, but their policies are lacking and they're missing a lot of people. And when we look at their bad debt file, we can give them good information about how their policies are falling short so that they can make changes that actually reduce how much medical debt they create as institutions. And so that's an area that we really are leaning into. Let's see. These are the areas that we think about for policy change, in case you're interested. Number one, before you walk into a hospital, making sure people do have as much good, affordable medical health coverage as possible. If they do have good coverage, we do know that they are less likely to get into medical debt, obviously, even though they still have a risk. And so there's been more and more done to try to have government subsidize health insurance costs for people, which does seem to be working, but it's, not cheap. The other thing is, when, as I mentioned earlier, more improving hospital financial assistance policies so that they're giving more free and discounted care to individuals. And then lastly, after somebody ends up with medical debt, ensuring that there is a limitation on what can be done in terms of collecting that. We don't think that people should be having negative marks on their credit because of it, because it doesn't really demonstrate, whether or not you're likely to pay back other debts. It's just, it's a different kind of debt. We don't think you should have to lose your home or have it, a lien put on your home or your wages garnished, things like that. So as I mentioned, we're trying to tell more and more stories of beneficiaries so that they can help inform this conversation. And I just wanted to share a couple of these stories with you. I think it really demonstrates the impact, on the individual. So here's, somebody who didn't wanted to remain anonymous, which is common because people feel ashamed and there's a real stigma around medical debt. You could see the amount we abolished is less than $900. Yet, the person is explaining that it's hard to get health insurance because it costs half of your income just to have that insurance. And then you're even getting an insurance that has high copays that are unaffordable, which is exactly what I was talking about earlier. You have to be really poor in order to qualify for Medicaid, which is the one program that the government does pay fully for your cost of care. This is really, I think, demonstrating that. That the person's concern, you could see the mental anguish about, going into debt or bankruptcy, either just to get medical care. And, they're questioning what's the solution. This is another individual in Oklahoma, the state of Oklahoma, again, less than $500 in this example. And they've said they've been paying $50 a month because they were taken to court over the debt. This really takes the stress away from them, the fact that we were able to help them. This individual, Willie, wrote a lot more, but if you see it, he said he's, tearing up, that he thought it was sort of unbelievable. He was sort of pinching himself that he got this letter from RIP saying that we relieved his debt. That it gave him, I find this statement particularly interesting, that it gave him time back, because I think he felt like he was so behind and he would never get to the place he wants to be in his life because this debt was weighing on him. And you could see the sense of relief and almost openness as a result of the debt relief we provided. And that, he literally says he could be a better version of himself. And, it's just sad. And again, this debt was about $2,000 that we got rid of for him. Yet it was really undermining his mental and physical wellness. He literally says that in this letter. I think this is the last one. This is Christopher in Tennessee, the state of Tennessee. You could see we relieved, in this case, almost $20,000, so pretty substantial. And that we obviously sent a letter. And he said he's been trying to pay this for many years. And also that there was garnishment on his wages. So that's, obviously problematic. I think he just had, it talks about what happened to him, something he couldn't control. He had a bunch of seizures because of a medication that he was on, and he was waking up in the hospital. And, there was nothing he could do about that. And then all of a sudden you wake up in the hospital in the United States, and you end up getting a huge bill. And there's, you can't even avoid walking in if you're, having seizures. And so, and unfortunately, if you're prone to seizures and you're obviously of ill health, having stress related to the financial implications only worsens your situation, and as he describes it here, it's a never ending cycle. So he, felt like what we did was amazing, and that's something he'd never forget. So this is my very last slide, which is the fact that we did a focus group in the state of Atlanta, and it really focused on what people are feeling. And so, they see inequities, they all feel like debt relief is important to them. They're definitely trying their best to fight back and negotiate against these bills, but they feel a lack of control, and they don't trust the system overall. And they're all, struggling, and they have multiple sources of debt. So medical debt is just one source of the debt in general. And I think this is a problem in a lot of ways, that we do recognize at RIP that medical debt is one of many debts, but that, it's important to recognize that removing that debt still is a really good support. And the fact that we can do it for pennies on the dollar, I think, is worth talking about. So I will stop sharing my screen there. And ask if people have questions. Some might have come up, but I wasn't watching the screen.
They do, but I want to ask a couple of questions. Sure. What did the hospitals charge on interest?
There is no one answer to that. It depends. Some of them do, like some hospitals don't charge any interest and will set you up with a payment plan that you could take 5 years to pay. It's still a burden, right? I mean, 5 years of adding that to your whatever, but that's some don't charge anything, and then others charge. Unfortunately, every state has can come up with its own rules. There's actually a effort in Arizona right now to limit. It's on the ballot. Like voters in the state can decide whether, and we'll find out in like 2 weeks is the election on this, and it's a ballot measure that whether or not there should be a limit to how much they can charge. That's a maximum of 3%. So obviously, if that's what's right now, it must be higher than 3% in Arizona.
Sure. And you said you can leverage 100 to 1. So for every dollar donation, you can write down $100 in debt. You've eliminated $7 billion in debt. You got 50 million from MacKenzie Scott, which translates to 5 billion. There's close to 200 billion. How much can you handle? I mean, if people hear this, wow, this is real, because you can probably put it to work quickly. So philanthropists like to see money actually helping. How much could you handle?
Yeah, I mean, honestly, so I should step back and say we're a pretty young organization. We started in 2014, so we're not even 10 years old. We were started by two former debt buyers who understood the debt market, which is why we have this amazing solution. I came on board right before the pandemic in January of 2020, and we got that gift about a year later. So we've been putting it to good work. The reason why I'm having this long walk to answer your question is yes, we can handle it, but we're also growing and building our capacity as we speak. So I expect that over the next 5 years, we will be we are going to be growing exponentially. I mean, I would hope that we didn't have to, but that's, I think, the reality of the situation. And we've done it so that, again, I mentioned investments in our debt engine. And really, if, we're trying to just be a loop of getting the money in and out. There is a little bit of time that it takes to like analyze a big file and all of that. But as long as it's really a matter of the debt getting to us as well, obviously there's a lot of debt out there. Part of what we have to do and what takes time is getting hospitals to agree to this and getting known to hospitals. So we've only been buying debt directly from hospitals for 2 years. So before when I first started here, we were mostly buying the debt that was already on the market from secondary buyers, so the same folks that we sort of compete with, which is fine. And we still do buy debt from them too. And getting it out of their hands is a good, move. But but we also want to, which is, I guess, a good thing. A fair number of hospitals do not sell their debt. They'll use collection entities, so it feels like it's not the hospital collecting on the debt, but they don't technically sell it. And so we are trying to increase the market in terms of our ability to buy it directly from hospitals. And we're able to get hospitals that don't normally sell their debt to sell their debt to us. And so it's a long way of saying it all depends on the hospitals, but we are doing incredibly well. So again, 2021 was the first year that we bought debt directly from hospitals, and 23% of our portfolio was from hospitals. This year, which is our second year, it's over 50%. So this is a solution that hospitals are responding to. And so I think our ability to spend that money and buy the debt. In fact, I'm sort of getting a little nervous that too many hospitals are going to want it, and we're not going to have all the funds, in which we just have to sort of slow down a little bit and say it depends on the hospital. We have to sort of say to the hospital, we need the time to raise the money.
And how did MacKenzie Scott know about you or connect with you?
She is a mystery. It's a very interesting approach. I mean, she's giving away a lot of money, like billions, and she's pledged to do that. They call you, they give you, like, she has a group that calls you. They don't tell you who is calling, who the donor is. They ask you a lot of leadership questions about how you run as an entity, making sure that you can handle a large amount of money, that you have good fiduciary mechanisms in place, that you have that you're thoughtful about your efficiency, that you're a well run entity and thoughtful and have good leadership board engagement, all of that kind of stuff. And then they just call you and tell you, here, we're going to tell you who it is and how much money it is. And it's kind of like you can't believe it. Like I thought it was like $1 million when I was being asked all these questions. I had no idea. And I didn't know if it would come with strings or no strings. It's unrestricted dollars, which is really incredible. And so, I don't actually know. They don't ever tell you exactly how they find out about you. I think my suspicion is that when I came to this role, there was, I think I was known because of my leadership at my previous role at the Human Services Council, which is an entity in New York City representing social service organizations. And I think that they might have looked at this model because at that moment we sort of elevated who RIP was to the world. And the fact that I was taking on this role was, I think, kind of in the nonprofit kind of news and things like that. And I think that that's how maybe I got paid attention to, but honestly, I'm not sure. They're very secretive.
I'm going to take Jacob had a question. It says, great model for helping rescue those who need it most. And it sounds like you are keen to change the entire system. His question is, what progress have you seen in that regard? It seems like Sisyphus trying to shift the system when it is so polarized politically. How are you shifting the paradigm nationally to be more open to broader change?
Very good question. And it's, it's a delicate dance to walk. I would say that this is increasingly we are in a polarized situation. And I don't think that's unique to the United States either. We are actually very conscious. And one of the things we're probably going to invest in the next year or so is actually the right language to use to talk about this issue, so it doesn't become a left or a right issue, because it really does affect everybody. It needs to be addressed and stay centered. I think like the kiss of death for any issue is when it's seen as like one side owns this issue, because then there's no more compromise and no more movement. So thinking about language and how we talk about it, we will work with both sides of the aisle on this issue. I mean, we really don't, whoever is in power will work with and talk to. We were invited to the White House in April, and we met with Kamala Harris, our vice president, about the issue of medical debt and several cabinet members, and they did, they did make some changes to what they can do without legislative changes. Legislative changes is really hard right now in the United States. And so what we're doing is we're leveraging the stories of individuals. Like those stories that I showed you earlier of all those people, we've invested in an anthropologist actually on our team who is working really hard to sort of bring those stories forward and put them into the public narrative so that we keep this issue alive and centered, and that we make sure that the voices of those being impacted are the ones that are leading the discussion. And so that's really what we think our role is in this. I don't think I by myself can solve this problem, but I think I can contribute to it, and I think I need to contribute to it, and that's how I think about this, our role in all of this.
You said that you were originally working with subcontractors or people buying medical debt and as a business. So now here's this nonprofit coming into the cement industry. So the mob, you're kind of ripping away some market share. How do they respond to you about that? I mean, do you get any death threats?
Well, I wouldn't take it, not yet, not that far. But interestingly, one of the bigger debt buyers in the country recently announced that they're doing forgiveness work.
Oh, wow.
So I thought that was interesting. And I don't know exactly what that means. It's on my sort of list to try to understand that more deeply. I'm sure it does not mean what it means for us, that they're really, truly forgiving it in the way that we are and letting and notifying people. But it probably means that they're really not going to bother with people underneath a certain income threshold, which is good news. So I think we are, sort of disrupting things and making them think differently. And I think that's in part because hospitals that sell, that do sell their debt sort of think like, well, if I could sell it to this one entity who's not going to harass patients and is just going to forgive it and make me look good in the press, or I could sell it to this for-profit, make the same amount of money, and then I have the risk of like showing up in the press because some patient tells their story and they were harassed in this XYZ way and I look really bad. So it's a pretty easy decision for hospitals, I think, to sell to us instead.
Most of the people that have joined live are not from the US. I mean, they might be American, but they don't live in the US. There's a couple, but some in Italy and UK, Norway, Japan, Sweden, Denmark. So maybe some of the terms might not have been familiar with them, like the copay story, because here it's kind of strange. You pay insurance, you just kind of don't worry about it. Or in the UK, you have national health, and it comes out of a different system. So this whole concept of medical debt seems to be unique to the United States. Or are there other countries that have the same issue?
Not any major countries have the same issue. I mean, the ones that are comparable to the U.S. all have some kind of national program or support system. So this is very uniquely American, and I think that historically, where it came from was, I mean, it's politics. There was an effort, to keep. Like every time that there was an opportunity in the United States to make a change here, there were campaigns that scared the public into thinking and misled them into thinking that was going to somehow take away their freedom or their right to choose or something. And that's a very American heavy value, is having freedom and being able to make choices of our own. And I think people are realizing increasingly, I mean, no one, I think, thinks now that the system is right, but still, how do we change it? And what are the compromises? And frankly, like, who gets credit for making that change is like the issue, I think, partially now too.
Yeah, we had once Wendell Potter. I don't know if you're familiar
Yeah,
with him.
awesome. Yeah.
Wendell, a friend, and he used to work at Cigna and fight all nationalized medical care. And then he freaked out what he had created and went the other side. And he's now very active in trying to change the system. And he was just saying, it's just, there's so much money being made by the pharmaceutical industry, the insurance industry, particularly the insurance industry, and some medical practitioners, that there's a lot of entrenched forces preventing fundamental change. Do you think that you'll still be around doing your work, or maybe you won't be there, but maybe the organization in 10 years?
I mean, God, I hope not. But I also, I think you asked like what day, right? Like, am I being more pessimistic? My glass half empty or half full that day? I hope not, but I don't know. Honestly, I think it really depends. I mean, again, the political situation in the United States is just really ugly right now, and it's been for a little while. Will we? I mean, honestly, I'm going to try my best to make this like an issue that comes up on the debate stage, but I don't know that that's going to happen.
Mm, mm. And
Did I lose you?
No. I'm still here. Can you hear me? Do you see me? You don't see me? Oh, let me
Just went back black for me.
Okay, let me reload. I'll be right back. Okay, can you hear me now?
Back in.
Yeah. Okay, sorry about that. A little bit of a technical issue, and Allison will join back in a second. It's just such a weird, if I look at some of the people in the session. Hi, Allison, can you hear me?
Yeah, I don't know what happened. It just went black.
Oh, it happens sometimes. It's okay. It's the medical industry blocking your message.
That's fair. Okay.
So because I mean, you basically want to put yourself out of business, and that there should be no medical debt. Have you ever met any of the people that, I mean, they sent you letters, but did you actually ever meet any of them? I would think that they would be incredibly thrilled.
Yes. So we haven't, unfortunately, like I started this job, like we're just starting to meet people in person in general. I don't know that I started this role right in the beginning of the pandemic, and it's so I haven't actually met any of them in person yet. But I do hope to. And again, we have heard from them not only in letters, but in like our anthropologist actually has one-on-one calls with them, and every week it's a sort of an inspiration to our team. Every week she shares an email like really explaining in deep detail kind of a conversation that she's had with one of our recipients, and to give context as to their whole situation and what this meant for them. And I think that's really inspiring to our team overall. So we do have more direct contact. In fact, some of them, again, intentionally, we've had them tell their stories on videos. We have this nice video of 3 or 4, it's on our website, like 3 or 4 individuals sort of sharing their stories, and again, what it meant to get the debt relieved, but what it meant to get in that debt and how overwhelming that felt and hard. So I have not, unfortunately, met them myself directly, but I certainly feel like I know a lot of them through the stories and through the anthropologist on our team that's tasked with really engaging them.
And how are you communicating, what you do and what you have done? I mean, 7 billion is incredible figure in a relatively short time, which when I look at how philanthropy is trying to, show how many lives they're impacting, and you can quickly show we can eliminate this amount of money. It's a relatively simple, straightforward, quick system. So how are you telling your story?
Yeah, so I appreciate that. I think a lot about that. I think it's important. I also think it's important that not only for philanthropists to support us, but for beneficiaries when they receive the letter to believe it, right? That's the other part that's like important for us to be a well-known entity. So we actually are in the process right now of thinking about our branding and marketing strategy overall, and what kind of things we can do to make sure that we become more of a household name, and lift up what we're doing and how we're contributing to the issue. So in the next year or so, we'll be like launching a new brand and really doing work to, and again, MacKenzie Scott gave us room to be able to do this kind of work, right? Which I think ultimately will fuel our ability to do this on a grander scale. Because again, being known, when people do hear about us, they tend to want to fund us because of to your point, especially, I mean, again, compared to other nonprofits, which again, I've represented for a long time, it's a little bit of a walk for you to give your dollar and then know what it leads to. It's like, well, in a few years, you'll eventually will address, these really intractable social issues, but with us, it's a very direct, like, you give us this much money, we will give you a report within, a relatively short amount of time that says you relieve this much debt for this many people. Here's where they were located. And here's even like, we will feed you back some of the beneficiary stories that I just shared with you and say, here's 2 people that they're thanking you for your donation. And so that's really, I think, attractive to people who want to fund, this kind of work.
Well, fortunately, I have a great person for you who's actually on this webinar now, so I'll introduce you to him afterwards, and another friend who made World Economic Forum a household brand when nobody ever heard of it. So we can help you on that. What would you like to raise in donations in, let's say, for 2023 that would really help you, not overwhelm you, but help you really tackle a larger chunk?
Yeah, I mean, I think anywhere between 20 and 30 million would be ideal. We're building our budget now, and we're not necessarily counting on that much money to be because you always want to budget conservatively so that you don't overextend yourselves. But yeah, I think anywhere between 20 and 30 million would be we'd be able to handle that based on the amount of debt that we, if you will, what we call our pipeline of debt, right? How many hospitals have been saying yes and have engaged with us. So I think that would be a good amount of money that I can.
Okay. Well, you're in luck because there's a couple of journalists who signed up, and one is the editor of Billionaire, which I guess what that magazine is about. And they are doing an article on this, so they'll watch the replay and reach out to you. So I don't think you'll have too much trouble, because in a really short time you show results. And that's really what a lot of philanthropists want, because everybody promises, oh, I'll do this, I'll increase people's educational level, or I'll cure cancer and that. But you have a very simple fix, and people cooperate. I mean, how long does it take to buy medical debt from one hospital?
I mean, not once. So there's a lot of variables, but in theory, it doesn't take that long once the hospital says yes. Like if a hospital says yes and gives us the file, I mean, it could take 2 weeks. Like honestly, it's not,
Wow.
as long as we have the money, right? It's not,
Right.
That's not long at all. It's really not a big deal. How long does it take to get the letters out? It really depends on how many other ones were, but still it's relatively short. What takes time is getting the relationships with the hospitals, getting them, they're big bureaucracies and they're skittish, right? So sometimes getting them to believe us that we're a real thing. That's another reason to do the marketing, that we are not, because they're bombarded by for-profit vendors that are trying to help them with their revenue cycle and with their ability to collect from people. And so we're talking to those same people who are always looking at these potential vendors that want to help them. And we're, looked at sort of skeptically, understandably. And so we've learned from that, and we're deploying ways of getting ahead of that. But that's part of the sell. So the sell to the hospitals is what can take some time. And it depends on whether or not, like, a donor really wants debt to only give money in, say, the state of Texas, then I have to make sure that I have access to debt in Texas. If they're willing to give just general medical debt relief, it's a lot easier because I can look at all 50 states and apply those dollars.
Okay. And so what specifically, I have a question here from Severine Ballack, a VC in healthcare. Allison, what you do is amazing, but beyond philanthropy, can't we collectively come up with ideas, solutions, insurance products to help the hospitals provide cheaper insurance to low-income patients?
I hope so. I mean, I'm all for other solutions. I definitely support that, looking at that. In fact, we just had a summit where we brought voices together to talk about solutions just like that one. Just 2 weeks ago. So I am all for looking at alternatives. I do not by any stretch think I am the answer here. And I do hope that we can have better insurance products. But I think that those insurance products, what we're seeing is that they are being propped up by government tax dollars, and that's how they're getting improved. I don't know outside of that if they're again, insurance companies are for profit for the most part, and so how do you? It's a difficult situation. That the economic situation and incentives are not really aligning towards helping the patient not have a financial burden, unfortunately, right now.
Well, didn't Jeff Bezos and Warren Buffett and J.P. Morgan, I think it was, didn't they try to come up with an alternative health insurance system, and they gave up?
I honestly, I feel like there's been so many like big splashy things, and I think eventually everyone does realize that it is hard because it's so it's all over the place. I mean, the system is all over the place, so it's hard to bring everyone together, and yeah, it's very broken.
Glenn had an interesting comment. He said, while I appreciate Robert's view on no medical debt in Europe, we will all have energy debt in a few months. Could Allison's method be applied for eliminating energy debt?
If there becomes a for-profit market for buying energy debt, then yes.
But could you use it as donations to a nonprofit to buy up energy debt.
You could, but you wouldn't be able to do it with their same return on investment that I get. So you could, yes, you could have, basically you're just subsidizing the actual cost then, right? But like what I'm doing is they know that they can't collect a certain amount of money,
Okay,
so
okay.
it gets deeply
I see.
discounted. So
I see. Yeah. Okay. Are you hearing? No, they hear they just turn off the gas or they just turn off the power. What can this audience that's watching now live and those that most will unfortunately be watching the replay because of the time issue, what can they do to help you other than checks? We've got somebody who can get your communications and storytelling there, someone that can deal with the media and philanthropists here. What do you need?
yeah, I mean, I think that the marketing piece is important to us and very valuable, right? So really just talking about what we do to other people that are influential, and I think that in and of itself is really helpful to us. I mean, being a known entity that is has reputational support, if you will, like people, it's a shortcut, right? If you have the right people that endorse and talk about your model and say, I looked at this and it seems like it's on the up and up. In fact, that was what a big part of the MacKenzie Scott funds did for us. It wasn't just about the money, but it was the vetting, being able to say we were vetted by somebody who decided that we were okay and a good investment of their dollars. That was really valuable. So I think anything that could be done to lift up who we are, what we're doing, and the issue of medical debt in general in the United States, I think is valuable to us.
It's interesting that our Japanese colleague who's from Tokyo said that she saw, although we have a different insurance system, she wrote, "Thank you for sharing your thought. I'm amazed by the transparent and fair business model. Although we have a different insurance system in Japan, but I'm sure there are people that need your services here too. So you can start working on your Japanese office." We're coming. Oh, wait a minute. Let's see. I have a question from Jen, our journalist. I arrived late to the presentation, so I apologize if you already covered this, but there is a federal law that grants hospitals the option of 501c charity status if they are willing to discharge debts of those who can't cover the debt based on income. Whatever happened to that system?
Yeah, actually, most of the hospitals in the U.S. are 501c3, and there is so they are charitable institutions, and a lot of the debts that we buy are from those kinds of hospitals. Unfortunately, the rules around that and the implementation falls short, if you will. Like the hospitals are able to make up their own charitable their charitable care policies and who they want to apply it to. So they're all over the place. They get to decide. And so I do think that that's a very important area to look at. Is that a lever which we can improve on overall? Like, can we? And hospitals, by the way, do give a lot of charity care away. They do, but there's more need than there is charity care. And honestly, what we see a lot of is people. Not only is it what the charity care policies are, but can they find them online? Like, can they? What's the application process? That tends to be a burden for people. And if you don't apply, then the hospital says, "Well, they didn't apply for charity care," and it's like, "Well, we couldn't find it on your website, or I didn't even know about it, or whatever it is." So there's a lot of room for improvement in that area. So it is a lever that we have. But it's also not the perfect answer, because if you honestly gave out charity care, if all hospitals gave out charity care to everyone that had medical debt, they would be insolvent institutions. And, they're not financially thriving across the board either.
Do you think that the $195 billion figure is understated?
Probably, yes. Well, I've heard upwards of $1 trillion. So.
Whoa. Well, that's a little different. That's 5 times,
Yeah.
the amount. So you'll be around for a while doing this. I wanted to try to take a group selfie because we're coming toward the end, and I'm cognizant of the time that you have. Just wave to the camera, and the camera will collect your photo and then add it to the other ones. And then I'll send everyone a group, and I'll send everyone a replay of this talk, so those who couldn't join live or those who want to watch the replay. And Allison, if you want to add anything to that final mailing, a link to your website, donation form, or whatever, you just send it to me, and I'll add that anything that you want to share. I want to thank our entire production crew for making this webinar possible. Sam, our producer, Crypto Genius, and Ramen Critic. Ricky, my absolute better half with no filter. Xi Jinping, our head of transparency and integrity. Vladimir Putin, military strategy and human relations advisor. Elon Musk, our humility coach. Kanye West, the director of brand value destruction. And Marjorie Taylor Greene, our MacArthur Genius Award for discovering the Jewish space laser. So thank you all very much. For those of you that like to join, I'm going to do a short mixer. Allison, you're more than welcome to come, but if you have to go, I'll get it. So thank you very much. And I'll send you I'll make some introductions to people that can help you move forward. So thanks again. I'll end the group selfie and then we'll go right into the mixer. Allison, you're brilliant. And thank you so much for all of this important work that you're doing, because I'm sure it might seem really easy, but you make it seem easy. So thank you for doing this. It's very important. So we'll go right into the party. All right. Thank you. Thanks again, Al.